I have a couple more. Good morning, everyone. Is my microphone on? It's on, yeah. Welcome to the session on implementation strategies, strategic approaches, and tools on a Friday morning. We have two very interesting presentations for you today from two speakers. DHIS2 is used nationally in a wide range of countries, as you know, but also over 100 large NGOs use DHIS2 to manage their own operations. So today we will hear from the Maldives about their experience implementing DHIS2 nationwide, and also from Doctors Without Borders, MSF, Médecins Sans Frontières, correct? My French. How do I change slides? That didn't work. This works. So we will have Aishat Samia from the Maldives speaking about the Maldives experience. We will have Chris Reinhardt sitting here talking about the MSF experience of implementing DHIS2 over many years. And we have Saurabh sitting over here, who is the lead of HISP India, who is supporting a wide range of countries as well. And then we hope we can be a bit interactive in the end, getting questions and comments from you. Before we start, I forgot to introduce myself. My name is... Yeah. Is this better? Better now? Yeah. Yeah. I forgot to introduce myself. My name is Anne Torsheng. I work at the HISP Center here at the University of Oslo here in Norway. One of the key things we do at the HISP Center is to develop reusable tools that can support countries and organizations in planning and implementing DHIS2. So we, of course, develop the software, but we also have a wide range of other resources that you can use free of charge and with our guidance and support. So I wanted to go through a few of those before our presenters start. We have what we call a readiness assessment tool. This is a framework that countries can use to see that have not yet started to use DHIS2 or an organization, that they can use to see, are we ready to get started, or are there certain things we should think about before we get started? So this tool typically asks for if certain data sources are available, if you have governance structures in practice, do you have the right skills in country, etc. So it's some key questions to ask yourself before starting to implement. We also have a tool that we call the DHIS2 Maturity Profile. This is the framework we have developed to assess current DHIS2 implementations, mainly countries using DHIS2. It was developed a few years back as a response to first partners wanting to understand what should we invest in countries, but we find that it's been very useful for having conversations internally in ministries and between ministries and funding partners. This slide here is a description of this DHIS2 maturity profile. We usually use this picture of the house that is standing on very shaky pillars to illustrate that if you're building an advanced DHIS2 system, you need to think about the foundations of that system. And the foundations are things like governance, it's having skills in the country, it's about having somebody that can pick up the phone if the user is calling and have lost their tablet in the river. There are many things you should think about before starting and planning a large-scale, expensive implementation. I won't go into detail of all those tools, but you're free to just search on our website and contact us later if you want more information. This really highlights that DHIS2 implementations are socio-technical systems. It's not just introducing the technology, but it's so much more. We have over 50 countries who have done this exercise together with the governments, and reports and recommendations are based on this, and they're open to read for actors who have an interest of implementing or supporting in DHIS2 implementation. We've also developed tools that can help you to budget your DHIS2 implementation. So these are Excel files, thinking about all the things we know cost money when you're implementing DHIS2, both when you are starting, but also recurring costs. Because we know that it's not only a start cost when you are starting to configure the system, etc., but there are certain things that you need to put aside funding for year after year. So this tool can help you to make a calculation on how much does it cost to train my end users, how much money should I budget for training our core team, etc. We also have an online course, it's also free and open, on planning and budgeting DHIS2 implementations. This is a self-paced course you can find on our website, where you can learn to plan large-scale implementations of DHIS2, identifying key aspects you need to think about. And lastly, we have tools for capacity building. Examples of this are generic job descriptions. If you want to hire people in a DHIS2 team, we have descriptions of key roles you should plan for and have in your team. And we also have capacity building needs assessments for DHIS2 core teams and countries. So do you have the right skills? Are there gaps in your team? And then also these tools can help you to plan like a capacity building journey for the team. What kind of courses should they take, etc. There was a session on this yesterday, I believe, by one of my colleagues. We could have had a full session just on these tools, but please, you know that they exist and you can reach out if you would like to learn more about them. And with that, I will give the word to Aishat from the Maldives.
Yeah. Good morning. My name is Samia and I'm from the Maldives. Today I would be presenting about the Maldives journey in implementing and integrating the DHIS2 across the country. We started our DHIS2 implementation in 2019 with aggregated data collection, but connecting like all the health facilities in the country. Health centers, hospitals, private public hospitals, and this included all the main statistical reporting to Ministry of Health, to Health Protection Agency, for policy making, for statistical reporting. In 2020, from the experience we gained in 2019 to 2022, we started implementing trackers, so individual patient information collection, starting with the immunization registry. The immunization registry collects information about immunization from birth to like any vaccination that's given through the life course. And in 2023, we implemented the primary healthcare module. So this is like mostly collecting NCD information. Collecting information of anybody like above 18 years of age, the risk factors for NCDs, disease, the treatment details, info of action. It also includes like SMS capacity for follow-up and reminders to people needing like additional care. In 2023, we also roll out the National Cancer Registry, but this is mostly for tertiary facilities, currently used in the tertiary facilities. We started with public tertiary facilities, but we moved on to like private tertiary facilities as well. In 2024, this was as a response to an outbreak. We have eliminated lymphatic filariasis, but this was a nationwide mass screening, and this was developed in-house by our team. And this year, we introduced the growth and developmental module. This is This captures information from 0 to up to like 5 years. This captures information on growth milestone development for children. So you can see currently in use, we've got both aggregate and tracker or patient specific information, collecting information in different public health programs. These are the modules which would next be like rolled out in the Maldives. First, we would be rolling out the maternal health module. This collects information on antenatal, postnatal care to improve outcomes for mothers and newborns. Second, we are working for TB elimination in the country. The tuberculosis screening tool tracker enables systematic nationwide TB screening and follow-up because when you go for TB elimination, you have to capture latent TB, which is like 1 in 3 people would have latent TB. So it's like mass screening across the country. Number 3, the communicable diseases surveillance. So this would capture real-time case reporting and investigation to strengthen outbreak response. Number 4, we are also working on tobacco control program across the country. So we have some policy interventions like vape banning across the country, and then rolling out of tobacco cessation programs like in all the health facilities in the country. So this will capture information from the tobacco cessation program across the country. So again, you see like in our development, so in our work in DHIS2, the focus is to drive better health outcomes for both communicable and non-communicable diseases, ensuring the data is not just collected, but it is used for meaningful use. Building on the expansion from our experience, I would just like to, there are many factors, but I would just like to highlight today some key factors which contributed to the progress for us. Number 1, there was like, we've ensured co-ownership. So it's not only health ministry, it's only not only health sector who is owning the data. We are leading these developments, but it's also other sectors. It's also the users, it's also the experts. So there are like core teams for each of these modules from the very beginning, throughout the development, through the monitoring phase, through the changes we are making to the systems. Second, we practice resource pooling. Each donor we find is interested in specific programs, but at a national level, we have our priorities. And these priorities are linked to the donors' priorities at some point, at different points. So resource pooling, aligning efforts of partners, there are a lot of funds available for digital health information systems, but to pool the funds to move with our priorities, so that at certain points we also align with the priorities of the donors, but at our pace and at our priority. Third, we've adopted a phased approach. This could be different for different countries, but with our capacity, we moved with a phased approach, but results-based approach. So with certain timelines, certain objectives, starting with specific programs and moving on to other programs. As I go through the slides, you would see how different programs, the information from different programs are collected together. Fourth, we've invested in local capacity. We've got very strong support from HISP community, from WHO and other partners, but there is a strong emphasis on local capacity so that our teams can manage and scale the system independently or confidently with the changes that needs to be brought in between. Fifth, we followed an agile model, adapting very quickly to real-time feedback when the change needs to be made so that it's relevant, there's acceptability from the users. And lastly, we prioritize community engagement, giving citizens access to their information through the Maldives Integrated Health Information System portal and building their trust, making them want their information, use their information to change their health. So like these are like some of the factors, but factors which are important to shape strong, sustainable, and creates a path forward for us in implementing DHIS2. Something we've heard and something that's critical in this journey is integration. First, DHIS2 unifies the key public health monitoring programs. We're using DHIS2 for public health program, like capturing information for public health programs. So there's data reporting, but there's also patient care, there's also monitoring, there's also follow-up, there's also like early detection. But mainly it creates, slowly this is creating a longitudinal health record of individuals. So it also gives information to the programs of their disease, of their program. This gives policymakers information about the overall health system, but also gives focus, also shows us where we need to focus, where there are gaps in the system. Second, we are focusing on health facility integration, which is just in progress. Currently, we are entering data, but then there's integration in progress, in process, so that when we link the facility level system with DHIS2, there would be like improved data flow. But most importantly, this will improve the quality of data. Rather than entering data, if the information flows, then this would lead to like better quality and ensuring more accurate and real-time insights. Third, the ongoing integration work with digital and national identification, because it's critical to identify the patient in each of these programs. Currently, we are using the national identity number, but it's entered into the system. With the integration, this would be automatic, and the information of the patient, of the clients would flow into the DHIS2 modules. It will help us eliminate redundancies and make it easier to verify individuals across different programs. I have an additional diagram, like additional image on the slide. This is the Maldives integrated public health portal. This brings all together. It gives citizens access to their own health data from multiple modules. We want to empower individuals. We want to emphasize that the information or the data that we collect is about the patients, about the clients. Might not be a patient, no, it's about the people. It's about improving their health. We also want to improve transparency. So from the beginning, the emphasis on quality of data. So if the citizens get access or have access to their data, they would also provide, they would also demand for data, they would also demand for the quality of data. This kind of integration and this kind of engagement with the public, we feel, would make the digital health ecosystem stronger, smarter, and more citizen-centered. These are just snapshots of the information that's there for vaccination. The information we capture, we make it very simple, not very complex. So if there is need to like add more data fields, we add. This shows the vaccination that's needed, that's given, and it sends a reminder to the parent before the vaccination. To drive real impact, we focus on like cross-sector collaboration. So collaboration partnership is key. First, across sectors, we're building strong collaborations beyond the health sector. For example, to cater to the requirement of Ministry of Social Sector, their requirement is to identify for early detection of like disabilities in children through the growth monitoring module that we have, which captures information on growth milestone development from 0 to 5 years. We're able to provide this information to the social ministry and to work together, not only on early identification, but also to provide the care at the right time. Otherwise, you wouldn't be able to detect them unless the patient or the parent comes with the child to the facility. We are in discussion with the Ministry of Tourism and Environment in exploring the possibilities of linking DHIS2 to climate, to tourism, health. So the scope is unlimited. We are working with the education sector on providing the immunization records. In the Maldives for school enrollment, you need the immunization record. It's a requirement for school enrollment, which drives our immunization rate high, but they also need the information at the right time. So the cross-sector collaboration is critical. It also ensures support from other sectors to DHIS2 and the health developments. We are also working with the education sector because there are school screening happening at 5 stages, 5 grades, from like grade 1 to grade 11, and they get a lot of information. So most of the children's first detection of disease comes from the school system, but this is not captured in the health sector information system. But we are working with education so that once we pull this information into DHIS2, this will be part of the record again of the person or the citizen. The previously mentioned digital ID integration with the National Center for Information Technology, again, is a major step forward. We also exploring the possibility of integrating different programs for other sectors as well. So we are listening, we are working together, but there is a plan and there is a priority on moving forward. The local leadership, the ownership, co-ownership is central, and stakeholders are engaged, as I mentioned from the very beginning. So very collaborative approach. This ensures sustainability. This ensures a cross-cutting platform for DHIS2, so all health information system in the Maldives. So going forward, for continued success, it's important to have a plan or to have key strategies mentioned on the capacity. So we'll just touch because this is just final recap of main strategies. So local capacity, I will just touch base. Second, linking DHIS2 with other systems so that it's not a standalone system. It's not a system for like one sector. It's a linked system. Third, to have a strong feedback and support mechanism. We have to listen to people because this is for the people. This is for the users. We have a user support platform, but there's also a support platform with experts, so that the support flows from the users to the expert. Fourth, we prioritize on accessibility. So user, citizen, that's critical in any information system. It's not about policy makers. It's not about program managers. It's about the users. So these are like some critical strategies or focus areas for us, like in our journey or in our implementation of DHIS2. Thank you all for your attention.
Thank you so much. Is this microphone now? No. Now? Can you help me? Now? Is it on? Now it's on. Thank you so much for your presentation. I think it's really, really impressive what Maldives has done in quite a short time. It's you're in many sectors, many programs, and talking to you outside, I think it's particularly interesting how it is driven demand, like starting and then others seeing the value of what's being done, and then they come and request to also be included in the DHIS2 journey. So with that, I'll give the word to Chris from MSF. I'm very interested in hearing how this large NGO has implemented and using DHIS2 and what's working well and what your challenges are. Thank you.
Thank you. Getting myself set up here. All right, hi everyone. It's nice to be here. My name is Chris. I'm representing many of us from MSF today. So I think you probably have all met maybe a few of us. There's lots of us here. So I'm just the lucky one who gets to talk to you, but there's many of us who can share experiences and they may all be different, to be honest. But I'm here to talk to you about MSF's implementation strategies as we embarked on our DHIS journey. So just to set the stage in case you're not familiar with MSF, we are a medical humanitarian organization with the core principles of impartiality, neutrality, independence, and bearing witness. In action, this means that MSF is providing medical assistance to people affected by conflict, epidemics, disasters, or in the context of exclusion or lack of access to healthcare. And this also means providing rapid emergency response when the need arises. Our geographic reach is global. You can see from this map that we reach many parts of the world, and we're operating in around 70 countries. As with our geographic reach, the health domains that we work in are quite broad. And these are reflected in the DHIS systems that we have set up. And really are captured both from an aggregate perspective and individual data models as well. I'm not going to go through all of these health domains. There's many of them, and that's kind of the point. And then in terms of our coverage, and before I really dig into the coverage that I'm presenting here, I want to make a comment on organizational structure, because this is really important to understanding some of the challenges and the complications that we faced as we implemented DHIS and how we're moving forward today. So from the outside, MSF is seen as one organization, but we're actually several organizations operating under the umbrella of MSF. You can see here, it says OCA, OCP, etc. These are operational centers, and we're operating mostly independent from each other in where we go and how we provide medical care. And so that also means our DHIS systems were set up separately. You can see we've been implementing DHIS. We started between 2015 and 2019. I also want to note that there's another operational center not represented here that's new and just started using DHIS. So maybe in the future we can also hear and learn from them. Operational center based in West Africa. But yeah, so this is an important note because I think it really underpins the complexity of our DHIS journey. So for the stats, as I said, we've been implementing since 2015 to 2019. We currently are operating or have DHIS implemented in 280 projects around the world. This number is always changing. So this is maybe our estimate from yesterday, but it might not reflect our numbers today. Again, this speaks to the dynamic context in which we work. And when we can do our work and when we can't. And we estimate that we are supporting around 5,000 DHIS users globally. This is users that are in all of the projects and then at all levels of the organization up to the headquarter offices. Our teams are relatively small, and we have about 35 people working on eHealth teams. On our eHealth teams and running our DHIS systems. So one of the things that really has impacted our success in implementing at the scale that you see today is due to the composition of our teams. So we are multidisciplinary teams. We're made up of application technicians, infrastructure specialists, data analysts, epidemiologists, project program managers, trainers, implementers, knowledge management specialists. We have a variety of experiences on the team and many with extensive experience within MSF projects and external and other large NGOs or international organizations. And so we have a wide variety of experience that we're bringing that makes up these small teams. But it's not only these teams that kind of make up our success, it's also how we place these teams. We're sitting within our organization, we're sitting across operations, medical, and IT departments. And we've developed a lot of collaborations at many different levels. So not only are we working within the MSF ecosystem, and collaborating with our GIS teams, health data protection, and security, information management, reporting, operational research. We also are supported and interacting with our external partners for a wide variety of types of support and partnerships that we're building. And then we can't forget that we also are interacting with our field teams, or the people in the projects who are entering the data, our data managers, supervisors, data entry operators, and the medical staff that work there. And so we are just a small team and a really big pool of people working together. And it's through kind of the pathways that we've formed that I think we can see how we've been able to reach this scale. And part of this really is due to the capacity, some of the focus we've had on capacity building. And so this is really due to leveraging the partnerships that we've had with external partners to build capacity within teams. So we've used our external partners to be able to bring in-house a lot of skills around configuration and the management of our infrastructures to allow us to be able to take on the day-to-day work of managing our DHIS systems. This isn't to say that we use our partners and then we don't use these external partnerships anymore, but it allows us to really drive these partnerships in new ways and try new things. So not using them for the day-to-day, but using them strategically to understand how we can move forward and leverage these partnerships in different ways. We also have developed extensive training materials for our users across the organization using different platforms and contextualized to the MSF context. So trying to meet the needs of the users. And so this is utilizing online learning platforms and in-person and virtual sessions, all tailored to our context to help people understand how to use the tools and why to use the tools. We also work towards building a community of users. So that's making sure that there's connections built across projects through regional trainings, or virtual office hours so that people and projects can connect across these projects and know that people are facing similar problems or have similar questions. One of the things that is challenging about capacity building, though, is high turnover. As an NGO, we do have people coming and going frequently, and so this is quite a big challenge. And in terms of how we kind of are thinking about this now and what we're looking to do more and more in the future is focusing on local capacity. So looking at our locally hired data teams and how we can build their skills and make sure that they are strong users of the system, to also compensate for some of the turnover that we see in other positions. Another thing that's important for us and something that we're working towards is building a data culture within MSF and supporting data literacy at all levels of the organization. This is a big task with an organization as big as MSF, but it's something that we're working on now. And then going back to what I mentioned about our complex organizational structure, we've implemented DHIS in parallel to each other, and so there's many things that we can learn in the methods that or in the approaches that we took in implementation. And so while we collaborate, currently there's always more collaboration that we can do in terms of sharing our lessons learned and how we're approaching reaching our field projects and supporting our users. Another key piece for our success is how we designed our systems and designing to go to scale quickly. So we focused on our core activities to integrate into the system. So this means that we were focusing on ambulatory outpatient consultations and inpatient services, some of the core medical activities that we do that are touching many of our projects. And then from there, building out our data models to include more specialized care or vertical programs, depending on where we're working and what we're doing. And with the intention to build in flexibility into our data model, saying we have a core of what we want to collect, but we also have extended data elements and options to be able to accommodate for the variety of needs that we see across our projects. But even though while we have this approach, we don't always meet the needs of our projects as we work in such diverse and dynamic contexts. So this has always been a challenge and still continues to be a challenge. For us looking towards the future, something that we're doing now is around the mutualization of our data model across MSF sections in order to be able to promote more standard data collection and also take in the wide breadth of what our activities look like. And ensuring that we have solid processes around the revision, the feedback mechanisms and the revision of our content. Our data models are not static in any way. They are always changing in order to make sure that we are responding to the needs of our context and activities. And of course, we're also working on data sharing because while we're separate, because remember, we are separate organizations, so we do have to talk about this. And then the last kind of factor around success and also some challenges that we face is around our technical processes. So we have developed a wide suite of tools and frameworks for how we can quickly deploy DHIS across our projects and contexts. And so this includes in projects where we have that are completely offline or with limited connectivity, how we implement in emergencies. So these are all processes that we've developed over time through experience and through being able to adapt quickly to the context that's presented to us. We've also established means for system maintenance and upgrade processes. I think over the last few years, we've been upgrading across all sections. So we have a testing framework that we've put together, and we're testing together, and we're teasing out bugs and reporting together. And I think this makes a much richer and more secure upgrade process for us in this collaboration. But some of the challenges that we face on the technical side is that while as we were all implementing separately and also had a large amount of work in front of us, we didn't always collaborate when we should have, or we weren't always talking when we could have. So there were missed opportunities there, which, as I've said, we are working to kind of rectify and to neutralize and to combine our efforts and learn from each other more. The other aspect is that we are also facing many challenges with our very dynamic context. So as our activities are changing, as where we're working changes quickly, we face challenges in making sure that we're adapting DHIS in the right way, and have the right tools to do so. We can go into more details. One example being how the org unit hierarchy works. We have org units that are opening and closing very rapidly, and so how does that look in our DHIS systems? Is something that we're always trying to work on. And also we have many users, as you saw, and we have help desk systems set up in order to support those users. But a challenge we face is the ongoing management of user expectations and managing feedback. With 5,000 users, we have a lot of different needs that arise, and feedback and expectations of the system. And moving forward, we aim to further neutralize our processes. We have technical groups meeting to share around the scripts that we're using, the processes, approaches that we're using to different aspects of DHIS. And we always are looking to further strengthen our relationship with UIO and the DHIS team. And I think that's all. So thank you.
Thank you so much. I will give the floor to Saurabh, and he's leading HISP India, has worked for many years, I don't know how many years, with DHIS2. 12 years, supporting a wide range of countries. I want to hear his reflections. I just want to note, sorry, that the next session, we have a very short break between those two parallel sessions this morning, so we need to end on time in 10 minutes. So I think we will end with Saurabh's reflections of hearing these two interesting presentations. Thanks.
Right, good morning, everyone. So I don't have a presentation, I'll just be sharing some reflections that I jotted down based on the past experience that we've had working with ministries and other partners. So these are, factors which we try to implement in ideal scenarios, but given that we work with a diverse set of countries, and for many countries, the context changes quite rapidly. So we work with countries which are stable, have good infrastructure and a good mechanism to keep supporting their implementations. But then you have countries where there's a lot of conflict and the priorities change quite quickly. And then, of course, the priorities for sustainability of the systems also change over time. So I think one of the key important factors that we keep into account when we talk about strategic factors influencing DHIS implementation is always keeping DHIS as part of the strategic governance. The DHIS should be part of the national digital strategy, linked with all other systems that you want to use, so that you're very early planning for using DHIS2 as the national HMIS, and you can also plan the interoperability around it. And then, of course, we need to have a multi-stakeholder arrangement and engagement with them. So we work with countries where there are the ministries, there are donors. So it's very important that we maintain alignment with them. The examples which the practices which the countries use, they are primarily using quarterly technical working group meetings and partner coordination meetings, where we call partners on a quarterly basis and discuss their priorities and their achievements till date, and what areas they need support from, and then to get a mutual agreement that which partners can strengthen which specific areas or priorities of the industry. The second factor that's important is identifying your health system needs and aligning your DHIS2 implementations on the similar lines. I think yesterday we had a very interesting session from DAO systems about return on investment on DHIS2, and they kind of gave examples on how they, using standard toolkits and packages available in the DHIS2 framework, they were able to save a lot of money in terms of the effort that went into designing systems. So I think UIO has worked with WHO to have these health toolkits, which are very important in terms of influencing the overall design of the systems that you build. So instead of starting from scratch for your health programs, if you use these toolkits as baseline and then contextualize them and use for your country's specific requirements, it saves a lot of effort in terms of investment that goes into from the team in terms of the ministry as well as the HISP group supporting it. So I think that's very important. I think the next point was on data quality and use. So that's one of the important pillars of sustaining your DHIS2 implementation over time. More recently, we have started working with the HISP Center in terms of piloting the use of the DHIS2 data toolkit, data quality toolkit. We're working with a couple of countries to try implementing that and see how we can have a direct contact with the ministry. We work with them on their HMIS instances. So, of course, we've seen Shuraji presenting that toolkit earlier in the week. And then, of course, moving forward by next year, we should have more inferences in terms of showing the actual results that the toolkits helped us to achieve. So I think those toolkits could be of very important use for both data quality as well as the metadata integrity. So these are two areas which we have recently started initiatives in working with the ministries to improve the metadata integrity of their HMIS instances and the data quality aspect as well. Capacity building again is a very important component. So again, yesterday we had an interesting session on the core team assessments in the ministries and the HMIS departments, and we did show some results that we achieved on doing these assessments with the ministries, and it really helped the ministry to see where their core team stands as of today and what improvements are needed for the profiles that are working as part of the DHIS2 core team in the ministry. So I think these toolkits are very helpful in terms of analyzing the potential capacity of the current capacity of your core team and where you want to reach over a period of time. Infrastructure, of course, plays a very important role. So, and of course, you need to look at your cloud hosting and infrastructure support as well. So I think we have been stressing a lot on having a scalable infrastructure and making mechanisms and training the local teams within the ministries, those who have qualified people, to in terms of how they can monitor their DHIS2 instances and keep a check on the security aspects as well. And those who do not have these resources, then we try to engage with them and see what best we could do given the limited constraints we have of the resources on the cloud hosting and the security aspects. Monitoring evaluation, one is of course with the data that you collect, but I think every implementation needs a health check at every certain years. So I think the DHIS2 maturity assessment tool that we try to implement in many countries gives a well-validated result that where your health system is doing well, where it is struggling, what are the areas that you should invest in. And that has given a clear picture to the donors that these are the areas where the ministry or the HMI, so the DHIS implementation needs more support. So they are able to target their funds on those specific areas. And if you're working with a multi-donor setup, then it's very important that you highlight these outputs of the majority assessment profile in a way that the donors can choose which areas they can strengthen and contribute, so that there's no overlap between the contribution they're trying to make. And lastly, on the sustainability, I think we always request the ministries to work on a coordinated plan, to have one trusted implementation plan, which could factor in all the important areas that you need support for, which include all the other factors, all the other areas I spoke about. And this one plan, one coordinated budgeting plan can be used as a strong tool to pitch to donors and to show them that these are our long-term plans. And these are the areas where we need support in terms of strengthening the HMIs further. So yeah, so those were the key lessons learned and the areas that we have worked with. But as I mentioned, these are the areas and the scenarios where you want to reach. But then, of course, country to country, there are variations where we struggle in terms of implementing or executing these respective interventions. But then, of course, as we progress, we try our best to work with the ministries and the partners and the donors to sustain these areas and make the implementation more successful and sustainable. Thank you.
Thank you so much, Saurabh. With that, I will end the session. Thanking our presenters. At the door, Ola will hand out some little flyer with the resources we mentioned. Do contact us. We're very, very happy to talk with both countries and NGOs on how to plan, how to budget, how to set up a DHIS2 in the most sustainable and smart way. That's the fun part of our job. So please do reach out. I want to say that the next sessions are starting in only 10 minutes, so 10:05. So it's different from the other days to get the logistics to start. In this room, there will be a session on DHIS2 in high-income countries. So if you're interested, you can just stay. Otherwise, be quick and have a look in the agenda to move somewhere else. And I hope everyone looks forward to the party tonight at the lake. Bye-bye.